Good morning, everybody. I'm Howard Chansky, the department chair for the Department of Orthopedics and Sports Medicine at the University of Washington. Welcome to our May Grand Rounds. I think we would all agree that if there's any topic that's dominating our email inbox, it's emails on diversity, equity, and inclusion. And for us as physicians, probably the real meaning of that is if we turn that into equitable healthcare for our patients. I think that's the bottom line for us. And so I'm very excited that we're having a grand rounds today on healthcare disparities. The actual name of the grand rounds is A Fractured System Casting Light on Health Disparities in Orthopedic Surgery. And our guest is somebody that I've known for quite a while, Dr. Cathy Humbyrd. And Dr. Humbyrd is now since January, the chief of foot and ankle orthopedics at the University of Pennsylvania. She is also the founder at Penn of the program in surgical ethics and health policy. She obtained her MD from Mount Sinai School of Medicine, completed her residency in orthopedics at Johns Hopkins, and then did a foot and ankle fellowship at Mercy Medical Center. Before coming to Penn, Dr. Humbyrd was also the chief of the foot and ankle service at Hopkins. And while there, she obtained a master's degree in bioethics from the Bloomberg School of Public Health. And in her academic career, Dr. Humbyrd has focused on the intersection of ethical issues in orthopedic surgery. Joining Dr. Humbyrd today for Grand Rounds is Dr. Cathy Vu, one of our stellar R4 residents. And I want to thank you both for putting together a talk on this really important and timely topic.
Good morning, everybody. Thank you, Dr. Chansky, for the introduction. I also would like to take a moment to thank Dr. Humbyrd for being so gracious in her busy schedule to mentor me in this talk, and also to Dr. Leopold for connecting this. I'm going to start my slides here. So our topic today is focused on health disparities in orthopedic surgery, and I hope today's talk is just the beginning to hopefully livelier discussion in person of this important topic. I personally have no disclosures. This past year, more than ever with COVID epidemic and current events, as Dr. Chansky alluded to, issues of disparities have been brought to our attention. And what I hope to highlight is that these issues have always been there, but may just need these recent events to really bring them back to light. The goals for my portion of the talk today is defining some common terms that we'll be dealing with, travel through the timeline of events and the creation of key legislations, review the landscape of health disparities as a field, and then going into more specifically orthopedic topics with a focus on trauma, amputations, and also joint arthroplasty. And then we'll also lightly touch on implicit bias and the cost of disparities, after which I'll turn over to Dr. Humbyrd for her expertise on this topic. So this diagram here from the Institute of Medicine report on crossing the chiasm in 2001 has a good depiction of how to think about disparity. So as we see here, it's kind of the difference in quality of healthcare between non-minority and minority groups due to a combination of factors, whether it's operation of healthcare systems, plus biases and discriminations from stereotypes. More specifically, when we talk about healthcare versus a health disparity, healthcare disparities refer to difference in race or ethnic groups in the quality of the care that they received. That's not related to access, clinical needs, or patient preference, whereas health disparities is when conditions are of a higher incidence or burden in certain groups compared to others. Another set of terms that we often use interchangeably but have different implications is equity versus equality, a concept Dr. Humbyrd will also discuss in more details in her portion. But briefly, we see here the depiction showing equity, which is a customized distribution of health determinants, resources to help achieve comparable outcomes within a population, versus equality, which is the same distribution of the health determinant resources to help achieve comparable outcomes within a population. So as Dr. King alluded to, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. The basis of health disparities can be traced further back than this timeline here, but this is an abridged version where we begin with Plessy versus Ferguson, where we commonly refer to as the origin of the separate but equal policy. And it's commonly known as social context, but this would permeate into the healthcare system. Using this as the basis, Congress would actually establish the Hill-Burnett Act in 1946, where they provided funding for hospitals after World War II. And while included a non-discrimination provision, there was still an exception made where separate hospitals and facilities are provided for separate population groups if the plan makes for equitable position on the basis of need of the facilities for each group. However, this does not always translate to truly equitable access to care. Simpkins versus Moses Cone would become more of a watershed case in the period of civil rights victories when plaintiffs were mounting legal challenges to the practice of delivering inferior medical care to Black patients solely on the basis of color. And this laid the foundation for the arguments for the Civil Rights Act, as we know in 1964, that stated that no person in the US shall on the ground of race, color, or national origin be excluded from participating in or be subjected to discrimination under any program that received federal financial assistance, which would virtually encompass every healthcare organization. In 1979, Cook versus Ochsner Foundation Hospital turned the tide by challenging discriminatory hospital practices, such as the refusal to admit Medicaid patients. And from there, the Department of Health and Human Service had to revise the law to eliminate the separate but equal provisions. In 1983, for the first time, a task force was created on Black and minority health, which led to the creation of the Office of Minority Health in 1986. Fast forward almost 20 years later, the Agency of Healthcare Research and Quality would start producing annually an update on the progress of national health disparities. Recognizing this as an important goal, the WHO also established a global commission looking at social determinants of health. And in 2010, I put on here the passage of the Affordable Care Act because in its core, it had some attempts at addressing some of the health disparities that we would see. So looking at literature addressing health disparities, W.E.B. Du Bois' study in 1899 would be one of the first ever analysis of the health of the Black communities, where he found that death rates for children, Black children under 5, was almost 82% higher than that of whites. In 1983, the Health and Human Service Secretary, Margaret Heckler, would lead the task force on Black and minority health to produce the Heckler Report. This represented the first time that health experts convened to study minority health. And the report detailed wide disparity and excess burden of death and illnesses experienced by Black and other minorities. They looked at specifically 6 conditions, including cancer, infant mortality, homicide, that accounted for 86% of excess Black mortality. And the report laid the foundation again for the creation of the Office of Minority Health. The Institute of Medicine of the 20th century would produce these 2 reports you see here, Crossing the Quality Chasm and Unequal Treatment, that would assess the extent of disparities in health and also healthcare in an attempt to provide a series of recommendations to address these disparities, some of which include collecting and reporting healthcare access data by patient race and ethnicity, increasing the proportion of underrepresented minorities in healthcare workforce, and then conducting research to identify these sources of disparity. One of the earliest studies in 1996 by Gornick looked at the effect of race and income on mortality and the use of services among Medicare beneficiaries. So they linked 1990 census data on median income to zip codes from the Medicare administrative data, and they found that mortality rates were higher for Black men compared to white males at 8.0 per 100 compared to 6.7. When they further stratified by income, the lowest income unsurprisingly had the highest mortality rates. Moreover, looking at access to care based on the number of primary care visits, as expected, there's also an increasing visit with increasing income. As research on health and disparities proliferated, more evidence accumulated in highlighting the gap that existed. This has especially been prominent in cardiology, where it's been shown that utilization gaps exist both in the preventative end of the spectrum to actual treatment of the disease. When we're looking at trends of all cardiovascular disease, including risk factors, some notable things were Black and African Americans have a 30% increased risk of death from heart disease. In addition, for the Asian populations, coronary artery disease also occurred earlier in life than in any other ethnic groups. Similarly, in obstetrics and gynecology, studies from the CDC have found that Black and American Indians experience higher pregnancy-related mortality, a trend that stayed relatively consistent throughout the years. As we can see on this bar graph from 2007 to 2019, the relative death rates were still higher than most. So as we try to understand more of what drives these findings of health inequities, one significant study published this last year by Bias offers some insight into how common clinical algorithms that we are taught in medical training and also use in our clinical practice can further exacerbate these inequities. Highlighted here are the different risk scores that we use in subspecialties that factor in race, but end up tilting the scale against minority groups. For example, GFR is something that we commonly refer to have different cutoffs for Black patients. And the explanation is that there's a higher creatinine release at baseline because, quote unquote, they're more muscular. But what this ends up doing is causing a higher cutoff for diagnosis of renal disease and delay in referral to specialists, and also for transplantation for end-stage renal disease. So I think the author's main takeaway, which I want to highlight here, since it helps provide a relevant framework for reading studies and for doing our own research when it comes to studying race, are these three questions that we should ask ourselves. Is race correlation actually based on robust evidence? Is there a causal mechanism for race difference that justify a race correction? And would implementing a race correction actually further exacerbate health inequities? Specifically in orthopedic surgery, a framing editorial on the complexity of reporting in race in research is written by our own doctors Leopold and Manner. And this reminds us that oftentimes race is used as a proxy for other factors such as poverty, education, and access to care. That said, some of the evidence may still be behind in fully taking this recommendation into account. So now to hone into more specific orthopedic topics, starting with hip fractures. In a study by Ryan et al. From New York University, a retrospective study looking at the NIS database, they identified patient and hospital factors that contributed to surgical delay. And the defined delay here is being surgery being performed 2 or more days after admission. They found that Black and Hispanic patients had increased risk of delays. In addition, Medicaid insurance also had a 50% increased odds of delay compared to Medicare. And as we can see here, private insurance actually had a reduced risk. Along the same line, Ali et al. Looked to see if this delay occurred even earlier in the care process in the emergency department by looking at disparities in radiographic timing and time to surgery. Black patients on average waited 3 hours longer for imaging for hip fractures. For this specific value, the hospital type in which they were in did not modify the difference in the radiographic timing. There was also similarly an increase in wait time to surgery, 41 hours versus 34 hours. Interestingly, the type of hospital did affect this timing, where Black patients at community hospitals had longer time to surgery. Surprisingly, in their specific study, there was no difference in length of hospital stay and 30-day readmission between races. In contrast, other studies have found that when there's a delay in surgical time, it can actually cause an increase in these factors because of complications. So in an attempt to incorporate the effect of socioeconomic status in addition to race in outcomes looking at hip fracture, Christopher D. from the Washington University in St. Louis evaluated socioeconomic characteristics with the use of a concept known as area deprivation index. These are validated geographic neighborhoods-based measure of socioeconomic deprivation based on census data. So similar to the previous studies, there's a delay in hip fracture that was found that was based on race as well as on insurance status. And there's also a finding of increased risk of operations for Black versus whites. The trend is also evident in readmission within 90 days and in 1-year inpatient mortality. When they did subgroup analyses stratified by these area deprivation index, they show that Black patients are at increased risk for delay in surgery and readmission, even in the least deprived areas, which is shown here as the lowest quartile of ADI. And then in another subgroup of minorities, Asian patients also have similarly increased risk for delayed surgery and readmission in all social deprivation quartiles. So this goes to show that even when we're controlling for socioeconomic factors, race was a factor in delayed care. Next, I want to delve into literature on amputation, which has some crossovers with vascular and interventional cardiology evidence. In a study looking at rates of amputation and limb-sparing surgery for peripheral vascular disease, Black patients were more likely to undergo all forms of amputations. What's interesting is that this higher rate of amputation was consistent even in patients without diabetes, so it can't be attributed to just worse baseline of chronic disease. When comparing rates of amputation versus revascularization procedures, Black patients were 1.5 times more likely to receive amputation. Similarly, Hispanic patients were also at increased risk of amputations versus any revascularization attempt. This finding is corroborated by multiple other studies showing that it's more likely that minority groups proceed directly to amputation before any vascular workup and revascularization procedures. So recently, Dr. Fagariti, shown in the lower right here, has been in the news highlighting what he calls the Black American amputation epidemic. He's a trained interventional cardiologist from New York and has since then moved to Bolivar County into the Mississippi Delta. Seen on the map is this dark area with one of the highest rates of amputations. Coincidentally, it was also the area with the lowest number of physicians per capita. So what he found is that patients with high risk of peripheral vascular disease were not getting screened. Preventative task force recommendations actually does not pay for this, and therefore primary care screening doesn't happen for these patients. And unfortunately, 50% of vascular disease patients are usually asymptomatic. And so patients with high risk for critical limb ischemia are not diagnosed early enough to allow for limb-saving interventions. Specifically in Bolivar County, he found that 50% of his patients who underwent lower extremity amputations had no prior arterial evaluation, no vascular procedure in the year prior to amputation. So his efforts have been focused on implementing the AHA guideline, which actually recommends that patients with peripheral arterial disease have an endo-revascularization procedure before amputation is considered. He set up his own interventional cardiology lab in Mississippi, and shown here the trends from when he arrived in 2014 to 2017. From his efforts, the rates of major amputations have decreased as access to peripheral angiograms and revascularization rates have increased. I think this represents a good example of how we can change these inequitable outcomes through a change in their access to care. The data for joint arthroplasty may be the most prolific. The CDC report shown here on trends of total knee replacement 2000-2006 showed that race disparities in knee replacement was potentially widening. Most of this data comes from Medicare, so access to procedure based on insurance was not as much of an issue. So to further characterize disparity in total knee arthroplasty, Skinner's all groups set out to determine whether racial and ethnic disparities are more pronounced in certain regions. And their first hypothesis is that disparities in national rates of total knee replacement is because of the region where Black and Hispanic patients lived, rather than just solely from the treatment differences offered. Similarly, they proposed that racial differences were also affected by income and residential segregation. So they use this concept of a hospital referral region as their geographic variable. The HRR, in short, is a region served by at least one tertiary care hospital. And the map on the right shows the map of the US broken down by these hospital referral regions as an example. So within each hospital referral region, they also determine the level of segregation based on if the dissimilarity index for Blacks was above or below the sample median, and also stratified it according to whether median income for Blacks were above or below the median income in other areas. So here we see kind of the difference in national rates across different race and gender for total knee replacement. Each dot here represents a hospital referral region, showing that in some cases you do see an overlap of cross races and gender. However, between groups like Black men compared to other, there's still a large gap in the rate of access for the total knee replacements. The bar graph here shows the role of geographic variations in racial difference in total knee rates. Their study found that baseline national rates for total knee replacement for white men was about 4.8 per 1,000, whereas for Black men, it was 1.84. When they corrected for the hospital referral rate of residency, referral region for residency, the rate of the Black men increased to 2.5 per 1,000, narrowing the gap. The correction also showed a similar narrowing of the gap across all groups. As part of their findings, when they took into account the income factor, they also found that Black men who lived in regions with incomes above median income for Blacks were getting closer to having similar rates of total knee replacement with their white counterparts. And what this showed is that higher income and lower level of residential segregation may in effect mitigate the effects of racial or ethnic differences. Again, in addition to just the race factor, I think socioeconomic factors such as insurance status also plays a role in access to total joint replacements and revisions. The study here by Kim et al. Did a phone survey of joint replacement groups using fictitious patient scenarios. So each quote unquote fake patient had a different type of insurance, whether it's private, Medicare, or Medicaid. They did this in multiple states, including those that expanded Medicaid eligibility. And what we see here is that for primary total knee arthroplasty, offices all agreed to see private insurance patients, compared to 96% for Medicare and only 30% for Medicaid. The rate increased in states that did expand Medicaid eligibility. Revisions showed a similar pattern. More recently, a study out of JBGS examined how geography affected joint replacement reutilization and whether the gap in utilization affected Black beneficiaries or mainly socioeconomically disadvantaged Black beneficiaries. So shown here is the rate of total joint replacement measured by the hospital referral regions, as we discussed before, across the country. Needless to say, you can see there's a stark contrast between whites and Blacks, even in the same year. So in this study, on this graph here, we see dual eligibility, which refers to patients who qualified for both Medicare and Medicaid, thus designating a lower socioeconomic group. Not only did the gap in joint replacement increase between white and Black beneficiaries, but the gap also increased within race with different socioeconomic backgrounds, Medicare only versus the dual eligible. The study also used the HSR concept, as we talked about, in finding that in HRR with large percentage of Black beneficiaries labeled here as quartile 4, there was a lower rate of hip replacements, 4.41 compared to 4.71, a difference of 6.4%. This difference we would see would also increase when they stratified the HRR by patients or by a higher percentage of dual eligible beneficiaries. Again, highlighting how insurance status and socioeconomic status further drives its disparity in care. So I think as we're learning about societal factors that cause these disparities, the joints literature has touched on also the individual ethnic reason for differences in joint utilization. What they found is that there's a significant difference in expectations and outlooks between whites and Black patients. Most jarring is the negative perspective about recovery after joint replacements, whether it's difficulty walking or more uncontrolled pain. It's not surprising then when we look below on this bar graph and see that fewer Black patients had friends or families who've had the procedure. This is a resource that could help modify some of their negative outlooks. So they went on to further test this conjecture about whether patient education could increase the chance of patients electing to have surgery or being more comfortable with the idea. So they exposed a group of patients, primarily Black patients over the age of 50 with knee arthritis, with indications for a joint replacement, to a decision aid, which was a 40-minute informational video about joint replacements, risk and benefits, and the actual procedure details, to a control group that only received a packet of information about arthritis and didn't go into the details about joint replacements. So they found that there's almost an 85% increase in the intervention group who opted for surgery compared to the control group. So suggesting that information dissemination and education in the perioperative period can be one tangible target to help close the disparity gap, especially when it comes to procedures that minorities may have limited access to. So I think after considering specific examples of disparity in orthopedic surgery, I think a talk about health disparities and contributing factors would be remiss if we didn't mention that in some parts, some of these disparities can stem from implicit bias from providers. It's not meant to stigmatize anyone with a racist label. I think implicit bias derives from this process of priming, where we have a stimulus that elicits an associated response, and we begin to form these associations without any conscious intentions. We're primed to make associations in response to messaging, policies, and our own practices and experience. And as providers, we rely on clusters of information to retain that large amount of information and to make assessments. And at times, this takes the form of applying prototypes or stereotypes that can lead to assumptions. In 1999, a study by Schulman stirred the pot a little bit when it looked at how physician recommendations were altered based on the patient's race and gender. The study had actors from different backgrounds that acted out patient vignettes with very similar complaints of chest pain. And what they found was that Black women were the least likely group to be referred for catheterization, even when they presented with the same complaints and symptoms. Now that we've pointed that out, how do we begin to identify the sources of these implicit biases? So Dana Matthew, in her book, Just Medicine, develops a bias care model to help parse out the components of implicit bias in our interactions in the healthcare setting to have more tangible targets for correcting for these biases. Taking a step back to more of the bigger picture, why health disparities also matter is the economic burden imposed by these inequities that's calculated based on direct costs, but also the indirect costs from productive days lost and premature deaths in minority groups. We can see here there's a staggering amount of almost $1.4 trillion lost due to these both direct costs and indirect costs from health disparities. Ultimately, for all of us here today, it's not so much about the bottom line that appeals to why we should care about these health disparities. I think it's more so the fact that our very own patients at University of Washington and Harborview represent a diverse indigent population who suffer from the effects of these health inequities every day. And as a providers, we have a role in starting to acknowledge these gaps in order to close them. So in normal times, we would be in Fagey Hall for grand rounds. So I thought it was fitting to conclude on this quote by Dr. Fagey himself. There are three essentials for good public health systems. The first is the conviction that the basis of public health is to achieve health equity. Therefore, the bottom line is social justice and health. Second is the understanding that science-based is epidemiology. It's epidemiology that determines gaps in social justice, identifies the groups with poor health outcomes, discover the details of these disease causation, and provides clues to how corrective action may improve health. And the third essential is the need for good management for efficient implementation of the corrective actions. So now I'd like to pass my virtual mic to Dr. Humbyrd.
All right. So thank you so much for having me. It's truly my honor and my privilege to get to be back remotely to the University of Washington. It's been a long time since I've gotten to be in Seattle, and I'm hoping I actually get to be in Seattle sometime soon. These are my disclosures. So this year has obviously been a year unlike any other. As I've been jokingly saying, the last year has been the longest decade of my life. And I think we're feeling that as a country. But in terms of ways for disasters to help lead to progress, this year has really highlighted, I think, for everyone, the depth and breadth of our healthcare disparities. This is a slide showing the coronavirus deaths and the disproportionate impact on African Americans in most states. You can see that Washington has less than proportional number of deaths, but more than proportional number of cases. And we can see the variety of different states, but overall, as a nation, our African-American patients have had a huge disproportionate burden of COVID, as have Hispanic and Alaskan Native people. When we talk about health disparities, we're not necessarily only talking about race. That is certainly one of the factors, as is ethnicity. Other factors that lead to health disparities can include geography and socioeconomic factors. And to highlight this, I always think it's important to think about the difference in caring for poor patients. One of my mentors teased me about a job that I initially took at Johns Hopkins as I was going across town from one part of Baltimore to another. And he had actually done the reverse job. And he said, you know, when you start working there, just be aware you're not going to be as good of a surgeon as you are right now, because your patients aren't going to have resources. They're not going to have money to get knee scooters, so they're going to walk on things. They're going to have worse health at the beginning, and it's going to be more work. And as I developed my practice, I had a practice in the suburbs as well as in Baltimore City, very similar to what I have now at the University of Pennsylvania. And it's one of those subconscious things that we don't always discuss, but it is truly harder to take care of resource poor patients. They're often coming in with worse health. It's going to be more work because they're not going to have as much support. And then the kicker, of course, we all get paid less for it. So I wanted to try and quantify some of the things that you feel in your gut about how much harder it is, and think about this in terms of access. This is a slide from a paper I wrote with a mentee, where we were looking at an all Medicare population. So insurance is not an issue. It's not just about coverage. And there's something called the Area Deprivation Index, or ADI, which can be calculated based on your 9-digit zip code. And there are measures of socioeconomic deprivation, and you can quartile individuals according to whether or not where they live. This is nothing to say about the individuals themselves. This is just location and geography. The level of deprivation in that region, from least advantaged to disadvantaged. And interestingly, these maps are not quite a mirror, but they're very close to a mirror when you look at the areas that were least disadvantaged and how many more hip and knee replacements are performed. I'm sorry, hip replacements are performed for those populations. And then this is one of those slides that you always hope that you're going to be able to get when you design a talk. And it shows the predicted yearly hip replacement rate per 100,000 individuals. And the green is least disadvantaged, and the light yellow is the most disadvantaged. And you can see how much your area deprivation index, your socioeconomic disadvantage as a function of your geography, predicts you're getting a hip replacement. So then we are now living in the area of the Affordable Care Act. There are multiple new models for payment. Are these policies working to improve or worsen our existing disparities? So my kind of first ethics project when I was a young faculty member at Hopkins was that I had returned to Hopkins after being a resident there, and our faculty had undergone a shift. And there was a new program. Maryland's actually exempt from the Affordable Care Act, but it was a bundled payment program with a large national payer. And when I had been a resident, there really hadn't been much optimization of patients for hip and knee replacement, which is not, I'm not saying that's a good thing or a bad thing. It was the way it was. But now, if your BMI was over 40, if your A1C was over 8, or if you were a smoker, you were unable to get a hip or knee replaced until you had modified those. And I found the BMI one particularly challenging after one of my ethics colleagues called me and said he had a patient who got the BMI from 55 to 41, but he still couldn't get them seen in our practice. So this was a challenge that I wanted to learn more about in the context of the Medicare bundled payment program. So I knew that Hopkins wasn't happening in isolation. So this program, and I'm sure everyone knows what a bundled payment program, but forgive me, I'll just say it in case there's anyone on the line who doesn't. The goal is that you get paid one lump sum for all the care, but there's minimal risk stratification built into it. So you are paid, and if you don't spend all of your bundle, the hospital or the physician, depending on the negotiated agreement between those two parties, is able to get a profit margin from it. Now, the goal was to try and improve quality of care because quality care should be less expensive. My concern was that this is going to lead to cherry picking and lemon dropping in terms of who received access. So we looked at a national model trying to see who would get care in this model. I'm sorry, my computer's being a little wonky. Can someone confirm you can still hear me?
Sounds good.
Everything's
Okay.
good.
All right, thank you. So who gets care if we try and optimize outcomes? So we used the NHANES, the National Household Survey, and just looked at what would happen if we use the cutoffs that are being used by my partners. And for each of these, the individual you'd expect to be healthier, so non-Hispanic, white, higher household income, those with more than a high school degree were used as the referent, and then we just chose men as the referent. And what you can see here is that throughout, we are choosing against, we are going to end up, if we cherry pick, we're going to be choosing against non-Hispanic, Black individuals, poor individuals, those with less than a high school degree, because these are all predictors of good health, right? Good health doesn't happen in a vacuum. So this study was from a few years ago. And then what has actually happened? So this was a recent study in arthroplasty, and they looked at the cost of care in a bundled payment model. And when they looked at Caucasians versus African Americans, it was interesting. The African Americans were on average younger, but they had higher rates of comorbidities. They had increased rates of discharge to a rehab facility with higher subacute rehab. And overall, when they controlled for confounding comorbidities, African American race was associated with higher episode of care costs. I think it's important to know, because when you start to wade into this literature and you just start doing PubMed searches, it can get confusing quickly. I am only looking at the cost of care here. We're not discussing outcomes in terms of patient-reported outcomes. There is some optimistic and promising early studies suggesting that a bundled care model may improve outcomes for African American patients. And that is hopeful. It is early. My overriding concern is that as structured, it is going to be discouraging us from caring for Black patients, those with lower income, and those with lower education. So how are we obligated to respond? So importantly, whenever you have someone who works in ethics and they start using words like obligations, we're getting into morality. Because if you have an obligation, it's not optional. So I'm going to try and walk you through how I think about it. And the challenge for me has been my medical school ethics, which, you know, I don't know if it's still the same, but I feel like we had endless Jehovah's Witness cases. We had endless cases on euthanasia, intrauterine diagnosis, how to deal with this genetic stuff. And it isn't relevant as an orthopedic surgeon to most of my day-to-day. When we get the occasional Jehovah's Witness patient, I feel like every time that happens, my residents and partners all call me because they're like, well, this must be ethics. This is what you do because this is what we were taught in medical school. And I don't know that our training is fully powered for us to think about the big issues of these population health concerns and how we as individuals are overall impacting society with our care. So when we learn these principles of medical ethics, the first three, respect for autonomy, beneficence, and non-maleficence, they all function at the bedside level. Justice is the only concern that is looking at a population-based level. I also think it's important, and anytime I give something touching on an ethics talk, I like to emphasize the reason that we have these principles of medical ethics. So the principles of medical ethics were developed because no one could agree on high-level moral theory. So utilitarianism versus Kantianism, no one could agree which should be right. So they took what was morally intuitive out of each of the great ethical theories, and they created mid-level principles. So it was, these are things that we think we can all agree on. And justice comes from egalitarianism, which it prioritizes equality as well as fairness. And overall, the idea is that patients in similar positions should be treated in a similar manner. You can imagine that this is really important when you're talking about research in developing countries, when you're trying to say what standard of care, where the similar patient, similar manner becomes incredibly important. So this is kind of where justice impacts on health disparities, because these are both societal level problems. However, these disparities occur related to our bedside practices. So what are our obligations when we can be agents of change, even though this is functioning within society? This does lead to a bit of a philosophical debate that we're not going to have right now. You can only have great philosophical debates in dark smoky lounges where someone is drinking tea or port or sherry. That's what I learned at my brief time at Oxford doing medical ethics. But we need to recognize we're having these debates with policy, whether or not we're engaging in them. And I think we need to engage more. So when we think about equality, that's not accounting for disparities. So we need to decide which one are we trying to go for. So what does healthcare look like under these rubrics? So if we're trying to evolve an optimal health system, is it based on equality or equity? Well, I think it's difficult to say, but right now when I would try and classify things for equality versus equity, Medicare seems to me to fit under an equality rubric. Over a certain age, everyone gets it. The VA health system probably matches that. You do a certain amount of service, you get it. It's not based on disparities. There's no means testing. Everybody's in the pool. I'm not sure about employee-based healthcare, right? Because not everyone can be an employee, but there is some equity in it, though you know, the ease of having it probably differs according to where you are within an organization. It was harder for me to think of equity-based interventions that are really focused on trying to get everyone seeing from the same level over that fence. So there are certainly healthcare interventions that include low-cost services for individuals in a low-cost household. I've seen the vans going around, which are offering free mammograms to areas of lower socioeconomic status, and where those vans go is not equally distributed in any city. You can think about health seminars or courses targeted to the needs of a particular community. So philosophically, you know, even though we don't have our port or sherry, we can still think about, when does an inequity become an injustice? And how do we look at success? Is success about access? Is it about outcomes? And regardless of our philosophical bend, you know, can we have a pure rule-based utilitarian agreeing with a pure Kantian? Are there some concepts that we can all get to? So in order to take it out of philosophy and into actionability, I've tried to dial in a few obligations that I think we have at an individual level, and then talk about a few obligations I think we have for a structural level. So these obligations as individuals, I wanted them to be actionable. I'm not attacking anyone. I think we can all be better. I am really into Adam Grant's podcast right now and focused on the fact that constant improvement is the way to excellence. And I certainly have ways to go on all of these. So these are the obligations I've structured. I'm going to walk you through each of them. So first, in terms of knowledge, we have an obligation to recognize when we have misunderstandings and to address them. So Black Americans are systematically undertreated for pain relative to white Americans. And this was a study where they assessed medical student resident knowledge. And they found that half of white medical students and residents endorsed beliefs, such as Black people's skin is thicker than white people's skin. And those participants who endorsed these beliefs gave less pain medicine. And it means that even those of us with some medical training have false beliefs about biology. What is the result of that? So these are the numbers of white versus non-white opioid prescriptions for the same injuries. We are systematically undertreating individuals of color for their pain. So our first obligation that I would frame is that we have an obligation of knowledge. You need to know the literature, and we need to develop mechanisms to try and prevent these types of harms. For example, and I know all of us want another checklist, like we want a hole in the head, but we should have standard opioid prescribing so that it's not catch as catch can, and it's not you're super sympathetic to this person, so you write them a little bit more. We need to just have algorithms. I know we've really shifted there, but that's novel. 10 years ago, when I was a resident, you wrote what you thought was right, and that wouldn't get them picking up the phone to call you. Our next obligation that I would frame is about language. And I torture all of my residents at both Hopkins and Penn with this, and any poor sub-I on my service, because I think the language matters. And this is a study actually by a colleague and friend of mine that shows how much it does. So when I say a 25-year-old male with a gunshot wound to the knee, I know what I picture based on the populations I've taken care of. Similarly, 25-year-old man with an ACL injury from lacrosse, I know who I'm picturing. How do we change this? How do we avoid stigmatizing language? So this was a study that looked at medically identical information, one with neutral language, one with non-essential language that had value judgments. And this was in a sickle cell population, just to frame it. So residents read through these and then decided treatment plans. So the first line is a neutral one, 8 to 10 pain crises a year requiring opioid pain meds, narcotic dependent in RER frequently. The neutral language, spent yesterday afternoon with friends, wheeled himself around causing dehydration. The stigmatizing, yesterday afternoon he was hanging out with friends outside McDonald's where he wheeled himself around more than usual and got dehydrated due to the heat. Neutral versus stigmatizing, pain is not alleviated by his home pain medication regimen. The other, it's not been helped by narcotic medications he's already taken. And this one, I find really interesting how we use the word appears. My verbal tick is he reports. He's in obvious distress versus he appears to be in distress. I will often, and I've tried to eliminate this from my notes, he reports 10 out of 10 pain. There's no reason to put the word reports. He is in 10 out of 10 pain. It's the subjective part of the note. You can absolutely document what the patient reports. So interestingly, those who read the stigmatizing chart note treated the pain less aggressively. Our language has real consequences. We need to try and go for neutral language whenever we can. Cathy has already talked about this, and I think it's really important. If you haven't taken your implicit bias test, you should. They're not perfect. I recognize their imperfection, but I think awareness breeds results in terms of being aware of it. We pause, we think, we reconsider. And our last obligation as individuals is to avoid microaggressions. And the challenge about microaggressions is that many people may not even be aware of them, which is why, again, I think it's important to reconsider our behavior, think about what we might be doing that is communicating some sort of bias. So an example here, we should not comment on how well an Asian American speaks English, because obviously there's a presumption that they're not from here. Black men being followed around in stores with the presumption that the Black person is dangerous or violent. This trended last spring on Twitter, and I screenshot it because it kind of just broke my heart, because I just imagined colleagues of mine having this experience. But when a professor asked someone to stay after faculty meeting when others had left because he'd seen a documentary about Black women sewing on other people's hair, and he yanked mine and said, "Is this real?" I don't know if that's quite a microaggression. I think that's pretty macro. So we need to avoid those. So let's talk about then, as I wrap up, hopefully we're going to still have time for questions, our obligations at the structural level. So this is a big theme of my career and my work. I do a lot of advocacy work within AAOS and the American Medical Association. And the reason is, if you're not at the table, you're on the menu. And I think we have a responsibility to do advocacy for our patients, for our colleagues, and honestly for ourselves. I find it rejuvenating to be trying to work to move medicine forward. I'm not going to define for everyone what your advocacy needs to look like, but if you opt out, you're still opting into something. You're opting into apathy. and you're saying that the system as it is acceptable for you. So this is a slide that I took from a New England Journal of Medicine, talking about, should we be considering healthcare reparations? I do think it's interesting that I get paid more to take care of the healthy, wealthy, who are often easier to take care of in terms of the amount of resources I need to mobilize from my teams, from social work, from my own time, often in coordinating care. It's easier to take care of the wealthy than the poor. I don't think the injustice lives in the past. It is continuing today, as this slide kind of demonstrates. I think it's worth a conversation. And this is something that I still have evolving thoughts on. I can't say this is what it would structure and look like, but I do think we need to consider it. And the way we would consider it is to look at our incentive structures and payment models and try and say, right now, we clearly incentivize the care of patients of higher socioeconomic status. And that's not going to fully change, right? We have private insurance, and that's probably always going to pay more than government insurance. But how does the government insurance plans disincentivize care, and how could we readdress this in something like a bundled payment model? We should have some more restratification, would be one argument I would make. Finally, on a hopeful note, because I hate to end on a sad note, universal coverage does help to ameliorate disparities. This is a slide taken from JBJS, looking at improvement in racial disparities in outcomes. So this isn't access, just to make sure everyone knows the difference. We're in outcomes, not access. But outcomes were improved for a universally insured population. This is out of the Kaiser Health Group. And even though it's not something that we can make actionable everywhere, I think this is promising, that when we get folks to all having similar levels of access, we're able to address some of the disparities. So thank you again so much. I really appreciate getting to be here, and I will take any questions along with Dr. Vu.
Yeah, thank you, Dr. Humbyrd and Dr. Vu. That was excellent. Anybody can either speak up or raise their hand under the reactions icon. That was a wonderful talk. Somebody must have comments or questions. I certainly have a few, so I'll start it off. So one of my questions is, because this is such a complex topic, and it's at the intersection of finances, ethics, medicine. One of the favorite expressions amongst orthopedic surgeons is no margin, no mission, for example, which is, I think, true to a degree. But what role does the diversity of the healthcare work pool play in trying to reduce these inequities? It's for either you or Cathy.
I think that's a great question. We know that patients of color feel more comfortable with a physician of color and tend to have better outcomes. And we know that the orthopedic workforce does not look like the population we're serving. So I think it matters. And I think it's wonderful that the Academy is embracing a lot of work towards increasing representation within our field. But I also think that we are able to take care of anyone, and awareness about these issues is really important. And for example, at my current job, I'm taking call, though as a division chief, I had the option to not take general ortho call. But I think there's something really grounding about when you take general ortho call, and you guys know this, you're at Harborview, where you get to recognize how many other people are living lives that look nothing like yours. And when you say, just stay off the foot, what does that mean for someone who works as a house cleaner and is undocumented, and then her kids aren't going to eat? Because I know that I'll do anything to make sure my kids eat, right? And I don't blame someone else for taking that approach. So having to think about that is one of the reasons I think seeing a diverse population and not drifting into our silos as pleasant and frankly easy as they can be is really important. And I think awareness is key. So just the fact that we're talking about this should lead to some level of progress. I am hopeful. I am forever an optimist, which is how you persist doing this work. But when I was at Penn in 2002, my senior thesis was on infant mortality and birth weight disparities between Black and white women in Philadelphia. And I remember when I wrote that, that blew my mind, and it was just starting to be something we were talking about. And then Serena Williams nearly dies as people ignored her pulmonary embolism. And, you know, she feels that it was in part due to race, and who am I to argue against that? It's kind of crazy because whenever I have to take care of a VIP, everyone's all over anything. And a woman with shortness of breath postpartum, like that's and she's had a DVT, like that's insane that was missed. So I think we are getting there with our awareness, and that's our biggest first step.
So it's really all of the above.
Absolutely.
Including diversifying our workforce. So there are now several questions. I'm going to take them in order. First one is from Dr. Henley, and it's at the system. He has a two-part question. At the system level, what steps can or should be taken to improve equity? That's, I think, a really broad question. I think he narrowed it down with his next question. At the level of hospital boards of directors, should there be criteria for individual board seats to improve decisions surrounding equity for a hospital? And should there be explicit targets?
So I am not a huge fan of quotas because I think it really impairs a cohesive functioning unit, if that makes sense. And if you're the person, so I'm a woman in orthopedics who works my bum off, but I still sometimes think I'm put on the AOFAS board because otherwise they wouldn't have a girl on it, and they know how bad that looks. So nobody wants to be the token person, and I think that quotas sometimes create a feeling of tokenism, rightly or wrongly. I think that we do need to think about our hospital boards not reflecting the community as much. And as someone who's done ethics work, the Berman Institute, where I was at Hopkins, had a community member, which totally changed the thoughts about doing research within the East Baltimore community, with their concerns being things that weren't on any of the ivory tower individuals' radar screens. So I think community representation, it doesn't necessarily have to be, let me find a person of color within the existing academic silo, but getting community engagement really changed our thought process. And so as a simple answer to, you know, a weekend retreat type question, I think, yes, we need it. I personally am not a huge fan of like, it needs to be this % diverse, so that then you're just adding people on until you hit that mark and they're like, okay, we're good.
Okay. Dr. Saha, I think I was told you also have a question.
First of all, I very much enjoyed those wonderful talks. You know, that was really excellent. It's simple, really. Most of the things that you mentioned, you addressed Blacks, but I presume those are equally true for other minorities like Hispanics and Native Americans?
They are. It's not a one-to-one match. And it's always a challenge whenever you talk about Native American health issues, because their geography and space and location are such influences depending on where individuals live.
Thank you. I'm going to direct the next question to Dr. Vu, and this is from Dr. Kwan. We obviously have a lot of DEI programs within UW Medicine, but Dr. Kwan's question is, what is the most effective way to formalize this type of education as part of the residents and faculty curriculum? So Cathy, you want to give that a shot?
Yeah, so I think I can probably speak more to the resident side of things. I think you can always go about it with a two-prong approach. Having something that's formalized is always nice, because again, you can kind of check it off and saying that, you know, you completed it. And if we're talking about that, then things that I can consider would be, journal clubs, maybe focusing once a year on these topics and staying relevant to the literature. I think it's always nice. And having a forum, again, just a more established forum to discuss those topics that's sponsored by the program. And then the other way is just on a regular basis, I think in clinical practice, when you're with a resident or even amongst each other, we subtly remind ourselves of these biases of kind of the patients that we see and other ways that we can provide better care to them. So I think that, if we were to start somewhere, I think we can definitely do a better job of talking about it. I think we can start learning the literature better. Even for myself, there was a lot of stuff that I learned from doing this talk and talking to Dr. Humbyrd that, was astonishing. And to the previous Dr. Saha's question, there's still a lot of information lacking on American Indians, and being in Seattle and the patients that we take care of, like I barely know what the baseline information is for their disparity of care. So I think that those would be kind of my contributions in terms of what we can do to address this.
Yeah, I think it's interesting that you alluded to just having role models, and I can think back all the way to medical school and still remember the different physicians in medical school, my residency, my partners now, who will, from my, perspective, take care of anybody that they believe they can help, in the same manner. And so I think that's really, really important. Alan Greenwald, Dr. Greenwald has a question. I work on a Native American reservation, coming back to what Cathy just talked about, and patient compliance is very poor. Regardless of bias, treatment disparities exist that are out of my control. What suggestions do you have? Dr. Humbyrd, you want to take a stab at that?
I will do my best. So I will say, and this is again a language thing, I try and reframe it as adherence rather than compliance. And when folks don't do it, I like to just ask why. What's the deal? I said, don't walk on it. What happened? And I have those conversations before surgery when I can. Obviously, you can't have them after trauma, and there you're always doing your risk benefit considerations. But we know that patients are often afraid to tell us what's going on because they see us as folks who are going to yell at them and criticize them. And I do think that I have some level of advantage of being a woman, and that patients are probably more likely and primed that I'm not going to yell at them, or if I do, it's kind of the mom yelling at them and I roll. So they're more open. They're like, doc, yeah, I just didn't do it. Or they'll tell me beforehand, I'm not going to stay off it. And I'll be like, okay, that's perfect. Let's not do something where I can make you worse. And that's a big thing I like to emphasize with patients. I like to emphasize that it's a partnership, and that I have, a couple hours of work to do, and then they have several months of work to do. And are they able to? I think there's an understanding gap. I think also in certain cultures, there can be this like complacency and calm, which is like, this is just going to be rotten, but it's rotten for everyone. And so for me, one of the things that was always fascinating is when you'd go to like a diabetic foot wound clinic. And like, to me, if I had a hole in my foot, and like you could stick a Q-tip halfway up my ankle, that would be traumatizing and terrible. And not only that, I don't know anybody else who's like that, right? I don't have anyone in my life who's just routinely going for that who aren't my patients. But when you're within a community that everybody's doing that, whereas my community, everybody is doing marathons and Peloton rides, right? That's the standard that I'm expecting to maintain for my health. When everyone else is at a different level of health, what are reasonable expectations? I also want to just say thank you for doing the hard work of taking care of the underserved. It is often a thankless job. You are often undercompensated for it. And we need people who are willing to do that and engage and care for the least of these. A huge part of why I, went into medicine is that rare privilege where you're fairly well paid and you get to feel super good about what you do most days. My husband's a prosecutor, which is the only way he gets to feel good about being a lawyer, but he's paid less than a school teacher, which is why he's married to me. But it's a rare privilege that we have, but it is hard work. And it is, I have taken care of many really indigent, poor, homeless individuals. You think that you're making progress and they don't. And I will tell you, it leads to physician moral distress and exhaustion. So the other point being, you have to find ways you can renew yourself so that you're able to celebrate the small victories, because with certain patients who are really entrenched in poverty and poor health, you will get burned out.
I'm going to put in a plug for the entire Department of Orthopedics and Sports Medicine. As you know, unlike most every other big city in the country, we really are the only safety net hospital in this region of the Pacific Northwest, certainly Western Washington, and so we definitely do our fair share of this kind of work. There's a couple more questions on the board.
Dr. Kavanaugh has a question real quick.
Yep, I'm going to get to Dr. Schmally first. And Dr. Schmally's question is, at Children's Hospital, there is now interest in ensuring equity of care for patients for whom English is not a spoken language. In-person interpreters are an advantage, but how might a clinical practice adjust or flex more time for these patient visits when we have an EMR? Of course, everything comes back to Epic, and Epic that fixes appointment times.
I don't have a brilliant solution to Epic. I defer to Dr. Tatesman, who's my Epic reference. What I have personally done is, when I was in Baltimore and I had a large Hispanic population, my coordinator adjusted everybody to a certain block in the afternoon. And then I just had the interpreter show up, and it was every Thursday from 2 to 4, and they'd finish out my clinic with me, was where we put anyone who needed a translator. And I made them assign a translator to me who would come and just be in clinic. So they tailed me and almost functioned as a scribe. And that was my fix, was that I blocked them together, and my poor secretary, medical office coordinator, had to flip everyone around, and she'd kind of put a little star in and utilize things within Epic, such that it then became routine, that the front desk and everyone knew that they had to be at that block. And there was an alert that you can use in Epic if you want to go all the way into Epic, which has the English not as a first language, or you can be preemptively filtering and flipping folks into a different slot. And if you get a routine translator, which I was blessed to be able to get this one woman to show up simply by buying her lunch every Thursday, well worth the investment. She essentially functioned as a scribe, and it wasn't nearly as slow as it would have been. But it takes more work, right? And that's the hurt of all of this. Taking care of these patients is more time consuming, and half of them were undocumented, where I'm happily signing the form that I'm doing it for free. Right? That's why medicine is in so many ways a calling, not a business. Don't tell the admins, they don't love to hear that.
Thanks.
And the last question is from Dr. Kavanaugh.
All right, great talk. So I guess I'll end it on a positive note. Hoping you could expand on the last slide. The Dr. Okike's study, that group reproduced that study not only for total hips, total knees, and hip fractures, and found data that not only contradicted other data, but was surprising to them, since they were looking for disparities. And I just wonder what wisdom, or besides access, because you referenced other health systems where everyone had the same access, what can we glean from that system when you talked about ideal systems that can help us with this?
So I think that my takeaway for it is, having insurance is a better thing in terms of your outcomes than not having insurance. How we get there as a society, I don't have great answers. And that's, I'm one of my partners in health policy is Zeke Emanuel, and he seems to think he has all the answers. And I really like Zeke, but I don't think anyone has all the answers on this health policy front of how do we get to a universally insured society without burning it all down. And I don't think we can burn it all down. It employs 20% of our population in the US is healthcare. We can't reinvent the wheel at this point. So we need to try and improve it. I am hopeful that we start thinking differently. And I do think we need the next generation of trainees and residents and faculty to be thinking like, how do we can't burn it all down. What would it look like in idealized fashion? What would I want if I didn't know where I was going to be born into this healthcare system? So if I didn't know that I was going to be blessed to be the daughter of an orthopedic surgeon and have health insurance my entire life, what system would I want given where, 60% of the population is at type thing? But I don't think universal health insurance is going to fix it. And I also would say about that paper, what I want to study is that's awesome that they were able to narrow the disparities. Tell me about the costs, because Kaiser's different. And I don't know what the healthcare costs were. And I know that in every other population, it was more expensive. And Kaiser is essentially almost like its own NHS, like they have in Europe. It's a captured population. So they're willing to spend more to save more. And that is not how any other insurer works. Did that answer your question? I feel like I dodged a bit, but I didn't mean to.
Oh, no, that was great. Just because they had reproduced that over 3 different diagnoses and found the same results. And so I was just wondering if there was something about that you had delved into, because other
California is weird. I don't trust anything out of Kaiser to be generalizable to the rest of the world. because they have primary care. It's just a different, it's like England. It's hard to generalize.
I'm not sure if you saw it, but there was just a big article, perhaps in the New York Times, about how Kaiser shorts patients on mental health care. It was actually, I thought, pretty insightful in some ways about how they run their business. Well, that was wonderful. This is an incredibly complicated topic tying together medicine, society, philosophy, ethics, and thank you for presenting it in a really digestible way and giving us a framework for how to think about this as we go about our practices. And I promise post-pandemic, at some point, we will figure out a way to get you back here in person to continue these discussions. So thanks, Dr. Humbyrd, and thank you, Dr. Vu. That was really wonderful.
My pleasure. Thank you so much for inviting me, Cathy, and everyone at UW. All right, I hope the mountain's out, and you have a great day.
Thank you so much.
All right. Thank you, everybody. Have a good day.
Have a great